Hello, my name is Drew Charles. I'm a current internal medicine resident, PGY2, at the University of South Florida in Tampa, Florida. Today I'll be presenting a case of MRSA colitis. When one typically hears methicillin-resistant Staphylococcus aureus, we tend to lean more towards a skin and soft tissue infection. However, emerging literature has been described MRSA being a cause of enterocolitis. I'll be presenting a case of fulminant MRSA colitis leading to MRSA bacteremia and septic shock. We had a 50-year-old male Caucasian school custodian with a past medical history of gastroesophageal reflux disease and nephrolithiasis who presented with left flank pain. On presentation, he was hemodynamically stable and he had unremarkable physical exam. He underwent a CT abdomen and pelvis that only showed hepatosplenomegaly and no evidence of nephrolithiasis. Labs were significant for a bicytopenia with leukocytosis in the presence of immature blasts on the diff, and his MRSA screen was positive on admission. He underwent a bone marrow biopsy which showed acute myeloid leukemia. He was started on prophylactic acyclovir, ciprofloxacin, and micafungin for his profound functional neutropenia. He was started on induction chemotherapy on hospital day 9, and by day 14 he complained of chills, night sweats, and diarrhea. On day 21, multiple episodes of large volume diarrhea with fever, tachycardia, abdominal cramping, prompting collection of blood cultures and transferring the patient to the intensive care unit. His antibiotics were escalated to vancomycin, cefepime, and metronidazole. Stool was sent for Clostridium difficile and GI PCR, which both resulted negative, and the culture was pending throughout the remainder of the hospitalization. He further decompensated, requiring intubation and vasopressor support on day 22, and unfortunately went into PEA arrest with return of spontaneous circulation on the same day. Repeat abdominal CT showed gastroenteritis and ileus. Antibiotics were further escalated to meropenem, and intravenous vancomycin was continued. Further decompensation occurred, and the patient went asystole on hospital day 23. Blood cultures later grew MRSA from two different sets, and stool cultures resulted in significant growth of Staphylococcus aureus. The patient unfortunately passed away despite aggressive resuscitative measures and antibiotics. Discussion. Although the differential diagnosis of colitis is broad, when it comes to infectious colitis, for example, most physicians would tend to think of Campylobacter, Escherichia coli, or Clostridium difficile. In immunocompromised patients with neutropenic enterocolitis, the etiology is broadened, including polymicrobial bugs, such as gram-positives, gram-negatives, and enteric anaerobes, such as Bacteroides species, Clostridium, and Candida species. MRSA is rarely considered. MRSA was discovered in the 1960s, and since that time, it has become a more ubiquitous pathogen in the hospital and community environment. Primarily, disease processes involved with MRSA include bacteremia, pneumonia, cellulitis, osteomyelitis, endocarditis, and septic shock. New data is suggesting that the intestines and rectum now have MRSA colonization rates as high from 10 to 60%. However, even with this colonization, MRSA rarely poses a risk of fulminant disease. MRSA colitis is similar to Clostridium difficile, which often presents with fever, bloating, diarrhea, and occasional multi-organ failure. A review of literature has uncovered, to the best of our knowledge, 6 cases as of 2015, with ours being the 7th of MRSA enterocolitis. Our patient's blood cultures were positive for MRSA, and the stool culture grew heavy growth of Staphylococcus aureus. However, sensitivities were not obtained from the stool culture specimen. Given the profuse diarrhea, the MRSA colonization noted on admission, the progressive deterioration on broad-spectrum IV antibiotics, and presenting symptoms of diarrhea, we determined that the patient likely had translocation from the gastrointestinal tract, resulting in MRSA bacteremia. The National Comprehensive Cancer Network and the Infectious Disease Society of America recommend consideration of vancomycin early during the febrile neutropenia in patients who are colonized with MRSA or those with hemodynamic instability. We believe that our case report is important as it highlights a rare but potentially fatal condition that must be considered when conventional treatments do not lead to clinical improvement. Below are our references, and thank you for this opportunity for allowing me to present our case of MRSA colitis. Thank you.